was mentioning, this is a clinical case that got me thinking about this problem. This is a 55-year-old woman who comes into the emergency department. For 2 days, one of her legs was particularly swollen. And so they went through and did some tests and diagnosed her with a deep vein thrombosis, a DVT, in her popliteal vein. And that's the vein that runs sort of behind the knee. And so at that time, she and the doctors had some decisions to make. They could admit her to the hospital and give her sort of the tried and true therapy of heparin through an IV in her arm and starting her on warfarin. They could treat her in the outpatient setting, so send her home and give her Lovenox or low molecular weight heparin shots while warfarin was starting. They could treat her with one of these new oral anticoagulants, the direct oral anticoagulants like rivaroxaban, also known as Xarelto, or apixaban, which is also known as Eliquis. Or the doctor could choose to engage her in a shared decision discussion, understand her values and preferences, and think about what would be the best choice for her, rather than just dictating her care. And I think that's really the ultimate goal for many of our patients. So I'm going to go through a little bit of what it means to engage in shared decision-making, what examples exist in patients with venous thromboembolism care, where there's opportunity that we could be using this more when doctors and patients are talking about their care, and then also highlight some examples from atrial fibrillation, because there's been a lot of work in that area. So when we think about shared decision-making, we have to understand what are the different types of decision-making that doctors and patients are often engaged in. And the first is sort of the very old school paternalistic doctor knows best situation. And this is where the doctor is basically the ultimate decider. Doesn't need any information from the patient, just makes a decision, tells the patient what to do. The next is something that's called physician as agent, sort of a fancy term that basically means a patient would share information with the doctor about their condition, maybe some of the things that are going on for them, but that the doctor, again, is going to make the decision based on all that information the patient has given to the doctor. The third, which is called the informed decider, really reverses that. The doctor now has to inform the patient of all the treatment choices, but the patient takes sole responsibility for making that decision. So the patient's completely on their own in the decision-making process. The last, which is shared decision-making, is really a situation where information goes both ways. So the doctor's going to tell the patient about the various options, what are the risks and benefits. The patient's going to share things like what are their values or preferences, and then together they're going to reach a mutual decision. What do they agree is the best thing for that patient? And this is sort of the model that I think we're trying to embody as often as possible. This has been really highlighted and encouraged by a number of agencies, and it's really the idea that when we take the best evidence on how we care for patients and we combine that with patient-centered communication skills, so really talking with our patients and talking specifically to them about the things that matter most to them, that's when we get shared decision-making, and that is what leads us to optimal care. And I think as a physician, that's one of the things that I'm always striving for. You know, this can be sort of a difficult thing to achieve, and so we will frequently use decision aids to help facilitate this. And so a decision aid is really a tool that has three components. The first component is it needs to help discuss a diagnosis or a treatment along with its risks and benefits. This is sort of the education component. The patients need to know about the decision they're making. The second, which is really important, is how do you help clarify the values or preferences the patient might have? What things are going to be important in order to make this decision? And then lastly, you have to actually encourage a shared decision-making process. Help encourage both the doctor or the provider, along with the patient and their family, to come to a mutually agreed upon decision. So these three components are what are needed in order to have a decision aid that really facilitates or helps encourage these kinds of interactions. This is one type of decision aid that you may have seen. This is a very popular one that the Mayo Clinic put out. And this is a decision aid that patients who are trying to decide if they should start on a cholesterol medicine and an aspirin in order to prevent heart attacks and strokes, they may use something like this with their doctor. The doctor would enter a bunch of information, their age, their weight, their gender, their blood pressure, things like that. And then here you would actually have a representation of what are some of the risks. So on the left side over here, what you're going to see is what is the current risk of having a heart attack. So if there were 100 people just like this patient, 26 of them would have a heart attack over 10 years, and 74 would not. That's the current situation. Now, over on the right side of the screen, you have what's the future risk. So if somebody started taking a cholesterol medicine like a statin and a baby aspirin, what would happen? And in this case, 15 patients would still have a heart attack. 74 would not. And that means that 11 patients would have been saved from a heart attack by taking the medicine. And so this sort of helps people understand what exactly are the risks and what's the medicine doing. In the middle here, you start talking about some of the other elements. Well, how much is this going to cost? How does this affect my daily routine? How often do I have to take the pills? Are there other benefits? Are there other advantages to taking these medicines? What about the side effects? What are some of the common side effects that you may see? Things like muscle aches, things like liver damage or kidney damage, things like that. So this really helps facilitate a discussion with patients about what are risks and what are benefits. It doesn't necessarily help clarify the values, what's most important to a patient. Another example of a decision aid looks like this, and this is something that maybe would be more familiar to this group. This is a decision aid from the United Kingdom for patients with atrial fibrillation trying to think about taking an anticoagulant or blood thinner. And so it asks the patients to say, for each of these questions, how important is this? How important is this of value? Whether I take capsules and once or twice a day, the risk of having a stroke, the risk of having bleeding, needing to change my diet. All of these are important questions, and the key is how important are they to each individual person. And so this really helps to go through that values clarification, thinking about the things that are most important to each individual patient. Now, there's some evidence that this is actually beneficial. We know that patients who engage in this sort of a discussion have better knowledge about their disease, about their treatment options. They're usually more satisfied. There's less uncertainty about what's going to happen. They feel more confident in the decisions they've made. And there's even been some evidence to say we can help to prevent unnecessary tests. However, there's some things that we just haven't learned yet about these decision aids. We don't actually know if using a decision aid will make a patient more likely to take their medicine on a regular basis, what we call adherence. Similarly, we don't know if it actually affects the big outcomes, like is it going to mean that you're less likely to have a stroke or less likely to have a bleeding event? And we also aren't really sure what impact it's having on changing how somebody's going to make a decision. People make decisions and they feel good about it, but how would that have impacted if we didn't have one of these decision aids? And so there's some things that we're still trying to learn. Most importantly, and I think this group probably realizes this, most doctors think that they do a lot more shared decision making than is actually happening. When some researchers have gone in and either audio recorded or video recorded interactions between doctors and patients, they find that the doctors tend to talk a lot. And then when they ask the doctors afterwards what happened, the doctors will say, oh, yeah, we had a great discussion. I listened. The patient had lots of times to talk. So doctors, I think, tend to overestimate just how much time they're allowing for shared decision-making and that they're offering patients to really share in that discussion. So what are some examples of this in the care of patients with venous thromboembolism? Well, we decided to look at all the published literature and find out where have decision aids been used. So we surveyed a whole bunch of different online resources that sort of categorize and catalog all published medical literature. And our initial search, when we used some defined terms, came up with 862 publications. So we were really excited. There's going to be lots of stuff published about this. But as we started going through one by one, we realized, no, this doesn't really fit. Maybe it's not actually patients with a DVT, or, oh, this wasn't really shared decision-making. This was something else. We got all the way down and only found 2 studies that we thought even came close to meeting sort of our definition of shared decision-making for patients with venous thromboembolism. So I want to talk about one of those studies here. It was an interesting study actually done in Boston. Patients who came into the emergency department who were complaining that they were short of breath, that's what dyspnea means, or that they had some kind of chest pain, but they were generally felt that it was unlikely that they had a blood clot in their lung or pulmonary embolism. So these were stable, low-risk patients. They all had a blood test done called a D-dimer, and it's a test that many of you may be familiar with. It helps us figure out how likely it is that you have a blood clot, either in your legs or your lungs. And for all of these patients, that D-dimer was very mildly above the normal range. It was not sky high, it wasn't scary, but it wasn't quite normal either. And we knew that in this situation, most doctors would just say, the D-dimer is abnormal, we're going to order a CT scan to look for a blood clot in the lung. That's just the way most doctors in the emergency room think. So the question was, do patients always want to undergo that kind of testing? And could a patient's values or preferences about the test help to avoid some unnecessary CT scans if we think the risk of actually having a blood clot in their lung is pretty low? So this is the decision aid that team used. And what you can see on the left side is they went through and tried to show all of the different risks that could be associated with having a CT scan. Because we know that every test has some risks. And here you'll look at things like, well, if there's radiation involved with a CT scan, that could actually contribute to a risk of developing cancer. Or we have to use some contrast or some dye to help light up all the different arteries so we can see what's going on. Well, that can actually lead to an allergic reaction or could actually damage a patient's kidneys. And then, of course, every test isn't perfect, so there's something that we call false positives. And so in that case, sometimes the test might come back and say, yep, there's a blood clot there, when in reality there wasn't. So we're treating somebody unnecessarily. So the left side talked about the risks of having the test done. The right side talked about the risks of skipping the test or not having it done. Well, if you don't go looking for it, maybe you'd actually have a blood clot. You might miss a small one. Or, more rarely, maybe there was a big one there that you missed. Or maybe you would have picked up on something else. Maybe there was a lung cancer that would have been picked up by a CT scan that you aren't going to find because you never did the scan. So it helped patients understand what some of the risks were. It didn't necessarily go through that values clarification I was talking about before, but they were able to have a pretty good discussion with patients. The results, I think, were really interesting. Over a third of patients said, Matt, I don't need to have that CT scan done. It's not really that important to me. And the most common reasons they said were, I don't want the radiation to put me at risk for cancer, or I don't want the contrast to put me at risk for injuring my kidneys, and I certainly don't want to have some kind of an allergic reaction. So the doctors who performed this study said, when we actually spend the time to discuss the risks and benefits with patients and engage them in the decision-making, it's possible that we could avoid a whole bunch of these CT scans that many people would say are really unnecessary. So it's sort of offering some opportunity that if we engage patients in the discussion, rather than just reflexively ordering tests, we may be able to improve the care we give, lower costs, and make it more better aligned with what patients want. So we did that big search, and we only came up with 2 decision aids that have been published, studied and published. So where are some other situations that we could potentially use this? Well, the key is that you have to have the right clinical situation, and you have to have the right patient. What do I mean by that? Well, you have to have a choice. If there's no choice to make, then we don't necessarily need to have shared decision making. So there have to be 2 or more choices that we would consider are clinically appropriate. It's perfectly acceptable to choose option A or option B. And more importantly, they have to be different enough that the patient's individual preferences might sway them in one way or another. So option A and option B, both of which are good options, they have to be pretty different so that some people would prefer A and other people would prefer B. And this usually happens when we don't have clear outcomes. We don't have a lot of evidence that says you must treat all patients in the same way. So that's sort of the situation that we have to encounter. But we also have to make sure it's the right patient. And my guess is it's going to be a lot of patients like the people who are here on this call. They have to be patients who want to participate in this discussion. They have a desire to be a part of their healthcare decision-making, and they're actually able to have a discussion. Obviously, somebody who can't communicate, maybe they've got dementia, it's not going to be a fruitful discussion to try and engage them in those types of interactions. One of the things I always tell doctors is avoid assumptions. You may think that the patient's room that you're walking into is somebody who just wants you to make the decision, but if you ask them, they'll often say that they really want to participate in this. So I often encourage other doctors to avoid assuming that they think a patient will or will not want to be a part of the decision making, and simply ask, how involved would you like to be in picking the right treatment choice or diagnostic test for you? So what are those situations? Well, many patients, when they undergo a hip or knee replacement surgery, they're at risk for developing blood clots, and we have a number of different medicines that we can give them to help prevent those blood clots. What's going to be the right medicine for the right patient? Is it taking a shot of Lovenox? Is it taking a pill, like maybe rivaroxaban or Xarelto? Or is it taking a less expensive pill? Maybe it's aspirin or warfarin. Those are going to all be very effective, but individual patients may have reasons to pick one or another. We talked about the diagnosis of a blood clot in the lung. Do patients actually want a CT scan if they're at pretty low risk? How about patients who have blood clots in their legs? Sometimes we choose to treat them if they're down just in their calf. Other times we say, well, let's watch this and have you come back in a week and repeat that ultrasound of your leg. Some patients may say, look, I just want to treat and move on. Others say, if I can avoid a blood thinner, that might be better for me. So that would be a great opportunity to engage in shared decision making. Now, the actual treatment when people have a blood clot, how do we pick the right drug to give them? Should we go with the tried and true warfarin? Should we use one of these newer meds, the direct oral anticoagulants? Different patients are going to have reasons to pick different drugs. Sometimes we have to use the clot-busting medicines, what are called lytic or thrombolytic medicines, in patients who either have blood clots in their lungs or blood clots in their legs. But we don't always have to use those medicines. So helping patients decide on whether they want to take that medicine or not. Increased risk of bleeding, but maybe some better outcomes afterwards. That's a great opportunity to have these discussions. And then, of course, for people who've already had a blood clot, and now we're trying to decide how long they should be treated, sometimes there's some clear evidence that we should only treat them for a short period of time or that they need lifelong therapy. But many people, it's not so clear, and so having a good discussion about that. If you've decided to treat them for a long period of time, what's the best medicine to use? Should you stay with the one they're already on? Should you switch to something different? All of them are pretty effective, and patients may choose different medicines for very good reasons. Of course, there are times when we shouldn't use shared decision-making. So when there's an emergency, when this is a pressure situation, we shouldn't sit down for 20 minutes and have a discussion. We should make the best decision as quickly as we can to make sure we're taking care of our patients. There are also times where everyone would agree that a single treatment is the best choice. If you have a blood clot in your lung, we all agree that the best choice is to take a blood thinner if you can do so safely, not just to sit and watch. So there are times where we definitely have to agree and we would just move forward. But maybe choosing which blood thinner to take is something that we should spend some time talking about. And of course, it has to be a patient who really wants to participate in this with their doctors. So what about atrial fibrillation, sort of the sister group of patients to the venous thromboembolism where we use anticoagulants? Here's a really interesting example that I found. This is from the AF GUST group, and they sort of came up with an interesting way to help patients think about what's important from a risk of bleeding and a risk of stroke. So they have a bunch of these different slides, and they're each personalized to the patient. So we know what their risk of stroke is, and we know what their risk of bleeding is. And what you need to do is you move along here along what's called the y-axis, or over here in this light blue, and you say, if I were to have a serious, severe stroke, what would I think my quality of life is like? Is it essentially unchanged? It's perfect, 100%? Or is it absolutely miserable? I might as well be dead, 0. Or is it somewhere in the middle? And you sort of pick what would it look like for me if I were to have a severe stroke. And then you come over here on the x-axis. This is the horizontal one where you see these faces. And you say, If I had a significant bleed from my stomach, what's called a gastrointestinal bleed, how big an impact would that be on my quality of life? Would this have no impact whatsoever, 100? Or would this be absolutely horrible? I just cannot imagine it, all the way down to 0. And where along this continuum do I sit? And when you find where you're at with regards to bleeding and with regards to stroke, you can pinpoint a spot. And based on your individual stroke risk and bleeding risk, they've come up with these different charts to help you decide whether you should choose to take a blood thinner because you would rather avoid the stroke and you're willing to put up with the bleeding risk, or if you're over here, you would not take a blood thinner because the risk of stroke seems to be less important to you than the risk of bleeding. And so this is one way to have patients sort of go through this process, think about what's important, and represent this graphically. Another group put this shared decision-making tool together where they asked really some key questions that affect choosing an anticoagulant. Things like diet restriction, and this is something I'm sure many of you are familiar with. When you're on an oral anticoagulant, you have to be careful about what you eat. It's not that you can't eat things, but you may need to keep some of those foods consistent, especially if you're taking warfarin. Well, how important is that to you? What about injuries? Many patients who take blood thinners are going to have bruising. They're going to have bleeding, especially with day-to-day activities. You accidentally run into something, or you knock your arm on the door. How important is that bruising and bleeding to you? How about needing to get your blood checked all the time? Is that something that you find to be a major hassle, or is that something you find to be really reassuring? And by going through and rating all of these, it can help you decide which are the factors that are most important, and therefore help you pick what's the best medicine for you. So if we go back to our case, if you remember, this was a 55-year-old woman. She had that blood clot in her leg. And when we talked with her, she said, I travel a lot. My schedule is very unpredictable. I really would rather not having to come in and get my blood checked all the time. That would be a really big inconvenience in my life. Also, I tend to eat out a lot, so I don't have a great opportunity to regulate my diet. But because of my job, I've got pretty good insurance coverage, so I'm open to taking any of the different medicines you may offer. Yet, I don't actually take any other medicine, so I'm not sure I would be very good at taking a medicine twice a day. I'd probably be better taking it once a day. So when we went through all of those things and talked with her about it, she and I sort of decided, maybe taking rivaroxaban or Xarelto would be the best medicine for her. She doesn't have to worry about the blood draws or the diet, so maybe she won't have to worry about having a Coumadin or a warfarin that's difficult to control. She's not going to miss those evening doses of apixaban because that's supposed to be taken twice a day. But most importantly, she really wanted a decision. She was the one who said, I really wanted to make this decision, and I had a lot of input in. And so I think she really felt good about the medicine that she was taking. So when I was thinking about this group, and I was thinking, what do you do to help encourage a shared decision-making discussion with your doctors, or at least get the information that you need? What are some tips or tricks that I could leave you with? And so I came up with a couple here. The first is ask questions and never be afraid to ask questions. Things like, what are the risks of this treatment or of this test? Well, what are the benefits? And how do I weigh those two? I think a great question is, what factors have influenced other patients' decisions? How did they come to the decision, and what were the things that were really important to them? And then you can reflect, are those important to me as well, or are those things that are less important to me? Often asking, is there a clear best choice? Is there something that really everyone would agree we should do, or are there a couple options that are all very reasonable? And then I think asking, why might somebody choose an alternative treatment, an alternative test, something like that? Because then you can decide whether the reasons somebody would choose the alternative are things that really are important to you, or if they're things that really aren't as important, and so you don't necessarily need to go with that alternative. I think these are great ways to sort of get some of that information from your doctor or healthcare provider. And really be active in your care decisions. The more engaged you are, I think the better care you're going to find. One tool I want to leave you with is the anticoagulation toolkit This was put together by a group of us here in Michigan, a bunch of anticoagulation care providers and patients. And we have lots of resources at this website for doctors and, risk calculators and dose things. But I want to highlight for you all, if you go to the website, there's a link up here that says patient. And we have a large toolkit for patients. It's in English and Spanish, and soon we'll have it also in Chinese and Arabic. And it goes through a lot of important questions for patients who are taking blood thinners. Things like, what is an anticoagulant? If you're on warfarin or Coumadin, how is that monitored? What do I have to do with my diet? What do other drugs do as far as interacting with them? How do I reduce my risk of having a complication? If I'm taking one of the newer drugs, what are they? How are they monitored? What are the things I need to worry about? All those sorts of things. So there's a lot of great resources that we've put out there, and these are all put together by experts and really importantly vetted by patients, so that they're things that answer important questions that patients have had in a way that most patients find very understandable. And I think they can help encourage some of those discussions with doctors.